Good day, students. Today we will start a cycle of lecture of a course of emergency medical care. I am responsible of the course, Roman Lechovich. So, when the situation with the coronavirus stabilizes, I would like to inform you that we have 3 practical classes which will be held on the basis of Regional Center of Urgent Medical Care and Medicine of Catastrophe, which located at 11 Repin Street. So, service of urgent medical care in Ukraine is a structure that the population of the state of a fast and urgent pre-hospital aid a different situation that can threaten to health or to life of a human. Urgent medical care, and that's one of link of primary help. For aid and treatment of calls, controls and separation responsible dispatching service. Basic mobile functionally structure unit of the station of UMC as a medical team that sends the call in place to provide necessary medical care in reanimation and emergency hospitalization of patients and survivors with the appropriate hits. Such medical care is named urgent. Urgent medical care on the greatest standards must be accessible for everybody and anywhere in any time. It requires the appropriate system of measures on medical care for all people whose life suddenly found oneself under threat, conception of grant of pre-hospital, hospital and inter-hospital urgent medical care. In time as a well-organized help reduced mortality, duration and rate of sudden diseases and traumas, decreases suffering of patients, so one of base positions of the manifesto of European Association of Urgent Medical sounds. In fact, its actual characteristic feature of our present time is an incessant increase of amount of accidents, catastrophes, elemental and ecological troubles, acute diseases that is combined by different pathological by that states. During the last years, as a result of psychic emotional loading, increase of rate and rhythm of modern life, the amount of cases of the so-called extreme pathology, to the heart attack of myocardium, violations of rhythm and cardio activity, disorders of the respiratory system increased. There is not a doubt that the endpoint of treatment of patients with such diseases of damages largely depends on the timeliness and adequacy of grant of pre-medical, urgent medical, pre-medical and skilled medical pre-hospital and early hospital help. So, organization of the emergency team in Ukraine. In Ukraine, the emergency medical care refers to primary link of the health care system. It provides emergency medical care for the population. 70% of emergency teams includes doctor, medical assistant, nurse and driver. Medical teams. The rest 30% of teams includes medical assistant, nurse and driver, paramedical teams. This slide presents the structure of medical brigade and the equipment of that, what they are responsible. So, development of systematization of algorithm and protocol of urgent medical care engaged. American Association of Cardiologists, European Association Council, ERC. Last recommendation was published in 2080 and includes next level of resuscitation measures: BLS, ELS, ILS, ITLS, PLS and ICLS. What does it mean by BLS? Basic of life support. Base support of vital functions, namely grant of urgent medical care on the pre-hospital stage by not physicians, by volunteers, policemen, firemen, rescue, etc., or the same physicians that by chance appeared in place of event. ELS, immediate of life support, is urgent support of vital functions that can come true in a polyclinic, permanent establishment, in a private cabinet, and others like that by medical workers to arrival of the specialized rescue medical brigade. ILS, advanced of life support, the extended is skilled medical including reanimation help that is given by physicians and paramedic with bringing of appropriate items, medications, tool on pre-hospital and to the early hospital stage. ATLS, Advance of Trauma Life Support, is a professional grant of the first medical aid at various traumas both on preclinic and on early hospital period, mainly executed by doctors, rare by medical sisters, paramedic. ACLS, Advance of Cardiac Life Support, is a grant of professional urgent medical care at cardiovascular pathology conducted by doctors, medical sister, paramedic. PLS, Pediatric of Advanced Life Support, is a grant of professional urgent medical care for children, comes through by doctors, medical sisters, paraphysicians. How to approach the injured person? Approaching the injured, ask a witness, rescue worker or policeman what has happened, whether the accident scene is safe and how many injured people are there. If the accident scene is, in your opinion, connected with criminal activity, immediately call the police. If there is need of rescue workers, inform the rescue service. In case of crime or violence, law enforcement agencies have to provide safety for the rescue medical workers. If there is a lack of information, act independently, first of all giving heed to everything which can threaten your safety. The place has to be thoroughly examined. If there is less danger, the container are marked with special signs, some liquid, split, smoke, fog, fire, gas, electric wires, explosive objects, things which can fall from the top, etc. Figure out if you are able to eliminate it without any risk. If not, call rescue workers. In this situation, it is important to keep verbal contact with the injured, find out what bothers him and give him recommendations concerning self-help and mutual aid. If you decide to approach the injured, figure out what has happened, to foresee the mechanism of trauma and to find out the way of providing medical help. Ask one medical worker or a driver to inspect all secluded corners of the accident scene in order to find other possible victims. In case they are found, you have to examine them and provide necessary medical help if it needed. Pay attention to the details of the accident scene. Keep constant control over the accident scene, since additional danger can occur, which will force you to save not only the life of an injured, but your own as well. The priority should be your own life, then the life of an injured, and then all people present at the accident scene. Find out if you need any additional help or additional means. So, this is modern algorithm of diagnostic and rendering of the emergency medical pre-hospital care is carried out by the so-called principle DIBC. D. Danger. Injuries are rare, safe for yourself, other, and the patient. Response. Level of consciousness according to LVPU principle. A. Airway. Open mouth if foreign material presence. Place in the recovery position and clear airway with fingers. B. Check for breathing. Look, listen and feel. Not normal breathing. Immediately start CPR. Normal breathing. Place in recovery position and monitor breathing. CPR. Start CPR 30 chest compressions. 2 breaths. Continue CPR until help arrives or patient recovers. And last, D. Defibrillation. Apply defibrillator if available and follow voice prompts. So, primary examination. Figure out the condition of consciousness according to the algorithm AVPU. What does it mean AVPU? A. Alert, conscious, give adequate answer to the questions, is able to perform conscious action when asked by the medical rescue. For example, are you okay? You are the victim. Yes, I am okay. V. Response to verbal stimuli, to a loud sound near the ears, left side, right side. P. Response to pain, response to pinch in the area of left thoracic muscle at the turn of 180 degrees. And U. Responsible. If victim not reaction for pain, his condition is regarded as very, very dangerous. If there is suspicion of simulation of unconsciousness, open patient eyelids using first and second fingers. The conscious patient will strain his eyelids muscle and they will open with tension. Remember, during primary examination, let's make a priori assumption that cerebral trauma occurs at transport accidents, sport accidents, falling from high places, traumas in water and children's traumas. Fix with your hands and neck part of the spine in the position which you found the injured in responsible fast assistant of brigade UMC. If that position does not promote breathing, carefully turn the injured on his back or to the position which is close to a stable medical assistant 1 and 2. Start primary examination according to the ABC. So, the Department of Emergency Medical Care for many years, in addition to teaching, is engaged in training in the development of theoretical and practical skills to provide qualified emergency medical care by teams of UMC. The latest medical equipment, medicines, and a set of mannequins are used for this. On this slide, you can see how the teachers of the department show the cadets' basic recitation measures on a mannequin. Also, very important information about golden hour. An algorithm of initial actions of brigade of UMC is in place of happening at the exposure of victims that need urgent medical care. Stage of actions of brigade of UMC and her job performance in parallel instances are based on the so-called principle of platinum half-hour and golden hour. Conditionally, platinum half-hours are divided into the parts of 10 minutes. First 10 minutes, arrival to the place of event. Second 10 minutes is an estimation of place of event, including realization of the medical sorting, diagnostics, measures and grants of the first aid in place. And third 10 minutes, transporting suffering in permanent establishment with continuation of realization of anti-shock measures and permanent monitoring of vitally important organs and systems in the coach of UMC. The gold hour includes for entails next 30 minutes, where to the victim in permanent establishment the various, including highly specialized methods of inspection are connected in the urgent order, as them computer tomography, MRT, and other like that, up to beginning to operative intervention. At the same time, there is another conception of gold hour, that interpretation rate of the state of trauma victims with simultaneous realization of the primary medical sorting in obedience to her damages and divided into 3 categories. 1. Irreversible, at that even immediate adequate interventions do not bring to the positive result. More often, the trauma hour what not consonant with life in the medical sorting are black victims. 2. Damages at that consequences of trauma, death or disability depend of timely and quality medical interventions are red victim. Help they get near term with further hospitalization for the grant of the specialized treatment in possible operative intervention during 1 hour from the moment of the got trauma. And 3. Damages at the grant of specialized Medicare can be deferred during 1 hour without an obvious risk for life and health or trauma are yellow victim. ABC principle. ABC and its variants are initialism mnemonics for essential steps used by both medical professional and lay person, such as first aiders, when dealing with a patient. In its original form, it stands of airway, breathing and circulation. The protocol was originally developed as a memory aid for rescuers performing cardiopulmonary resuscitation, and the most widely known use of the initialism is in care for the unconscious or unresponsive patient. It is also used as a reminder of the priorities for assessment and treatment of patients in many acute medical and trauma situations, from first aid to hospital medical treatment. Airway, breathing and circulation are all vital for life, and each is required in that order for the next to be effective. So, step A. Provide to patients airway support. Responsibility medical assistant number 1. Evaluate airways if there is need examine oral cavity. In case of secretion, blood, vomitive mass, outside objects, depending on the mechanism of an injury, it is necessary to open oral cavity. Usually between molar teeth you should put a spreader to prevent accident pressing of fingers. Take out outside objects with medical tongues or tweezers and tampon. Provide cleaning of oral cavity and pharynx. Clean them from secretion. If they are severely injured, the priority is to place them according to the relief of area, head down. Put the patient's head back and raise his chin. In case of suspicion of cerebral trauma, it is prohibited to throw patient's head back. You should raise only his chin. Step B. Make sure if the patient is breathing. Count the frequency of respiration during 10 seconds. Intubation of trachea is considered the most effective way to ensure airway patency and mechanical lung ventilation. Indication for carrying out trachea intubation: apnea, risk of aspiration, danger of presence of respiratory disorder, damage of respiratory tracts, maxillofacial trauma, closed craniocerebral injury, hypoxemia in spite of carrying out oxygen therapy. So, continue step C. In almost all medical and surgical emergencies, consider hypovolemia as a likely cause of shock until proved otherwise. Unless there are obvious signs of a cardiac cause, angina, chest pain, heart failure, give intravenous fluid to any patient with cool peripherals and high heart rate. In surgical patients, rapidly include bleeding, overt or hidden. Remember that breathing problems such as attention pneumothorax can also compromise a patient's circulatory state. This should have been treated earlier in the breathing assessment. In the following slides, I want to show you the equipment that is modern Ukrainian ambulance according to modern clinical protocols of emergency medicine, which were adopted in Ukraine in 2020 year. So, you can see on this slide a chair for immobilization, transportation, welcome barrel. Next slide, please. You can see hard shift, soft stretcher, type of frame stretchers, electrosuction fan, right side upper pulse oximeter located on the finger on patient, cardio complex, medical bag for transfers of medical property and medicines. This is immobilization, neck collar, pectoral immobilization, Westcott and vacuum splint, other splints, Kramer splint, elastic splint, type some splint, and elastic tip, yes, suction units, patency airway support, respiratory mask. You can see alternative method to intubation, laryngeal mask and laryngeal tube. Yes, different calibers, laryngeal tubes. Also very interesting combi tube to provide patency, or respiratory mask and ambu bag with connected by oxygen. Yes. A set for cricoterotomy. A cricoterotomy is often used as an array of last resort given the numerous other array options available, including standard tracheal intubation and repeat sequence induction, which are the common means of establishing an array in an emergency scenario. Cricoterotomies account for approximately 1% of all emergency department intubations and in used mostly in persons who have experienced a traumatic injury. Some general indications for this procedure include First, inability to intubate. Second, inability to ventilate. Third, inability to maintain saturation more than 90%. And last, severe traumatic injury that prevents oral or nasotracheal intubation. So, general intubation for indications for intubation. Remember, absence of independent breathing or less than 10 during 60 seconds or more 40 breaths per 1 minute. Yes, saturation less than 90, early period of burns of the respiratory tract. So, this slide presents the portable of respiratory equipment, left side support artificial ventilation of lungs, and right side oxygen therapy. This is training mannequin for developing skills of patency or reverse support. Yes. This slide presents the algorithm for diagnostic and performing primary and secondary examination of a victim in serious condition, from primary examination to secondary examination with category patient load and go. So, category load and go after primary examination. Under the following circumstances, a patient must always be allowed and go. Altered level of consciousness. Next, any compromise to the airway, any compromise to the breathing, any compromise to the circulation, deadly bleeding, change of skin color, temperature or condition, spinal immobilization has been taken, pelvic fracture, femoral fracture, and internal bleeding. If head of brigade determines the patient to be allowed and go, the following protocol must be followed. Note the patient history can usually be taken at the same time as the patient is being packaged. Patient history, package patient, begin transport, check vital, recheck vital every 5 minutes or if a change in the patient condition occurs, performs a assessment survey and begin treatment. Stay and stabilize. If none of the above conditions exist, head of brigade may choose to stay and stabilize the patient before transport. If head of brigade determines the patient to be a stay and stabilize, the following protocol must be followed. First, patient history. Second, check vital, recheck vital every 5 minutes if a change in the patient condition occurs. Third, perform a reassessment survey. Fourth, begin treatment. Fifth, package patients. And sixth, begin transport. So, on the next part of my lecture, we will talk about respiratory and circulatory arrest, model algorithm, cardiopulmonary and cerebral resuscitation. So, one of the most important tasks of becoming a physician is to acquire the skill of cardiopulmonary cerebral resuscitation, which allows to renew the vital functions of life. Okay, on this short video you can see how close the death can be to anybody. Intensive therapy and resuscitology. Concept of intensive therapy is a complex of temporary method of artificial maintenance of vital life functions in the compensated stage, which is directed to provision of life support. Resuscitology. Study about revival of the organism, prophylaxis and treatment of terminal stage according to Nigorsky. Non-traumatic, unexpected fatal event occurring within 1 hour of the onset of symptoms in an apparently healthy subject. If death is not witnessed, the definition applies when the victim was in good health 24 hours before the event. The term is used when congenital or acquired, potentially fatal cardiac condition was known to be present during life. Autopsy or autopsy has identified a cardiac or vascular anatomy as the probable cause of the event, or no obvious extracardiac causes have been identified by a postmortem examination, and therefore an arrhythmic event is a like case of death. So, terminal states is divided into several stages: pre-agony, terminal pause, agony, and clinical death. Pre-agony: falling of arterial pressure, loss of consciousness, decrease of metabolism. Terminal pause: arterial pressure and breathing are reduced, functional of the central nervous centers becomes chaotic. Third, agony: further fall of the blood pressure, cessation of breathing, and a sudden return to consciousness for a few minutes. After that starts steep reduction of all vital functions in their last spark of life. And fourth, clinical death. What does it mean, clinical death? Time of cessation of blood circulation and breathing, the two criteria necessary to sustain the lives of human beings and of many other organisms. It occurs when the heart stops beating in a regular rhythm, a condition called cardiac arrest. Main sign of clinical death and additional sign of clinical death. Main sign: absence of pulsation of mediastinal arteries, usually carotids or femoralis, jugular. Second, pupils are fixed and dilated, not reactive to light. And third, abscess on independent breathing, or one breath per 10 seconds. Additional signs: change in skin color, sometimes possible gray, bitter or cyanotic. Second, absence of consciousness. And third, absence of reflex and loss of muscle tone. So, CPR involves chest compression for adults between 5–6 cm deep and at a rate of at least 100 to 120 per minute. The rescuer may also provide artificial ventilation by either exhaling air into the subject's mouth or nose, mouth-to-nose technique of resuscitation, or using a device that pushes air into the subject's lungs, mechanical ventilation. Current accommodation places emphasis on early and high-quality chest compressions over artificial ventilation. A simplified CPR method involving chest compressions is only accommodated for outright rescuers. In children, however, only doing compressions may result in worse outcomes, because in children the problem normally arises from a respiratory rather than cardiac problem. Remember, chest compression to breathing ratio is set at 30:2 in adults. On this slide you can see quick evaluation: type of blood circulation blockade with defibrillator plates, center picture, and right side adhesive electrodes. So, on this slide you can see modern protocol of CPR according to last recommendation of European Resuscitation Council. You see, left side, right side, different situation, different way. First of all, must remember, we have rhythm prior to defibrillation and rhythm not to defibrillation. Rhythm prior to defibrillation, ventricular fibrillation and ventricular tachycardia, not to defibrillation, pulses electric activity and asystolia. So, up ventricular fibrillation and down ventricular tachycardia. Ventricular fibrillation, if we feel the ventricular myocardium depolarizes randomly, the ECG shows rapid, bizarre, irregular values of widely varying frequency and amplitude. VFE is sometimes classified as a cause of fine depending on the amplitude, height of the complex. If there is doubt about whether a rhythm is asystolia or pulse electric activity, do not attempt defibrillation. Instead, continue chest compression and ventilation. Very fine VFE that is difficult to distinguish from asystolia will not be shocked successfully into a perfusion rhythm. Continuing good quality CPR may improve the amplitude and frequency of the Wi-Fi and improve the chance of successful defibrillation and a perfusing rhythm. If the rhythm is clearly Wi-Fi, attempt defibrillation. Ventricular tachycardia, VT. Ventricular tachycardia, particularly at higher rates or when the left ventricle is compromised, may cause profound loss of cardiac output. Paraventricular tachycardia is managed in the same way as Wi-Fi. The ECG shows a broad complex tachycardia. Is monomorphic VT, the rhythm is regular or almost regular at a rate of 100-300 per minute. Evaluate rhythm. If you receive rhythm prior to defibrillation, immediately do ECG. Post-ECG control, receive fibrillation, immediately do defibrillation. Biphasic 150-200 joule, monophasic 360 joule. After that, immediately defibrillation, post-ECG control. Only post-start defibrillation used medical drugs. Remember, after performing defibrillation, continue CPR for the next 2 minutes. Stop CPR only when patient has signs of circulation. Defibrillation priority. Adrenaline 1 mg with normal saline in syringe, the same 1 cc post-start defibrillation. Amiodarone 5% 300 mg, the same 6 cc with glucose in syringe, also post-start defibrillation.
In a real clinical setting, an AED system is normally used. At the Cape, we use a monophasic defibrillator. You must place the paddles on the mannequin's chest plates when using the defibrillator. Many institutions are switching to the biphasic defibrillators. Our mannequin can only be used with a monophasic defibrillator, which can reach 360 joules as compared to a biphasic system, which can only reach 200 joules. The defibrillator is fully functional. Depending on your scenario, the defibrillator can be used as an operative defibrillator or the use may be simulated. When using the defibrillator, the left paddle is placed on the sternum and the right on the apex. Effective use of the monophasic defibrillator requires 2 individuals. Release the paddles from the defibrillator by using the release mechanism located at the left and right side of the defibrillator. Turn the main dial clockwise and select Monitor. Press the lead button until the word paddles appear on the screen. Place the paddle on the sternum and the other on the apex. View the waveforms on the defibrillator monitor. If your patient needs to be shocked, turn the dial clockwise and select defib. The individual assisting must be informed of the desired energy level. 360 joules, please. Push the energy button until the desired energy level is selected. Then push the charge button. A low-pitched noise will occur, alerting you that it is charging to the desired energy. A high-pitched noise will then sound once it has reached the desired energy level. Before delivering the shock, you must inform your care team to clear the area surrounding the gurney or bed. A commonly used phrase is, "I'm clear, you're clear, we're all clear." It is important to maintain eye contact with the care team when announcing this. Once the surrounding area is clear, use your left thumb and right thumb to push the corresponding orange buttons located at the top of the paddles. A shock may now be administered. After administering the shock, leave the paddles on the mannequin's sternum and apex plates. Viewing the waveforms on the monitor will alert you to the status of your patient. You may then act accordingly regarding use of the defibrillator.
So, rhythm not before defibrillation. Up on up asystole, down pulses electric activity. Asystole. Usually there is neither atrial nor ventricular activity, and the ECG is a more or less strange line. Deflections, which can be confused with fine Wi-Fi, can be caused by baseline drift, electrical interference, respiratory movements, or cardiopulmonary resuscitation. A completely straight line usually means that a monitoring lead has disconnected. Whenever asystole is suspected, check that the gain of the monitor is set correctly and that the leads are connected correctly. If the monitor has the activity, view another lead configuration. Atrial activity, P waves, may continue for a short time after the onset of ventricular asystole. There will be P waves on the ECG, but not events of ventricular depolarization. The patient may be suitable for cardiac packing. Pulses electrical activity, PA. The term pulse electric activity, sometimes referred to as electromechanical dissociation (EMD), means normal or near normal electrical activity without effective cardiac output and is treated as cardiac arrest. The diagnosis is made from clinically absent cardiac output, but a rhythm that would normally be accompanied by a good cardiac output. So, remember, action if you receive asystole or PA, check for electrode connection, adrenaline every 1 mg every 3 per minute during CPR. So, potentially treatable conditions 5H and 5T. 5H, hypovolemia, hypoxia, cardioganglion acidosis, hyperkalemia, and hyperthermia. 5T, toxins, tamponade, tangent pneumothorax, thrombosis, heart acute massive, and thrombosis lungs massive. On this slide you can see ways of drug administration during cardiopulmonary resuscitation. Intravenous, intraosseous, intratracheal, intra-arterial. So, intravenous access for emergency care, for example, in the United States, easy, 68%, yes, hard 17%, and impossible about 15%. According to other data, providing peripheral intravenous access in the pre-hospital stage can take 10 minutes or more. Peripheral intravenous access cannot be established at all in 6–10% of cases. At the last time, grade popularly intra-bone access as alternative for intravenous access. In this slide you can see indication to use this method. Pediatrics, children in critical condition without attempts to establish intravenous access, and mass cases, catastrophe, and other problems. So this is modern automatic devices. From left side, sternal semi-automatic device, new bone injector. In the middle, electric drill with a needle from USA. And alternative, this method, bone injector gun big from Israel. So, and drug which used at the CPR, oxygen, adrenaline, amiodarone, lidocaine, magnesium sulfate, calcium, natrium, bicarbonate, dopamine, and hormones. So, students, remember during CPR, rule out potentially treatable conditions, check placement of electrodes, check IV or intraosseous availability, airway patency and oxygen. Remember about after maintenance or airway patency, conduct continuous chest compressions, inject adrenaline every 3–5 minutes, choose amiodarone magnesium. Summary. Algorithm ALS standardized array of treatment for circulatory arrest in adults, all to increase effectiveness on treatment. Thank you for attention.
Ambulance service. What's happened? He's gone to bed and he won't wake up. He won't wake up? Okay, what's his name? John. John? How long has he been like this? I don't know, he went to bed about 15 minutes ago and I can't wake him up. Okay. Hello, John? John, can you hear me? Yeah, there's no pulse. He's in cardiac arrest. Can you help me get him on the floor? Right, you've got him under the shoulders. Yeah. Ready, set, lift. And start some compressions, please. Yeah.
Adult pads. Don't touch patient. Analyzing.
Can't detect a pulse. Can you continue compressions, please? We'll treat this as a non-shockable arrest.
The end of the second.
Thank you. There's air entry, but I'd like to operate to an option. Airways clear.
25, 26, 27, 28, 29, 30 is end of force.
Thank you, that flows better.
Twenty-five, 26, 27, 28, 29,
30. Thank you. Thank you. Air entry.
That's over the fifth maze.
Air entry.
Should we go for 6?
Air entry. Yes, please. Sorry, John.
29 and 30. So that's the end of the 6.
Okay, thank you. Thank you. I'll just do another rhythm check. So it looks like a sinus rhythm.
And connect this up.
Thank you. There's no
no
pulse. Just compressions, please.
Do you want me to take over airway as well?
Yes, please. Just gain some access now. sharp scratch, John. Just doing a rhythm check. There's no pulse and still a sinus rhythm, so you continue compression, please. Preparing the first lot with adrenaline. You just check that's adrenaline 1 in 10,000?
Yeah, it's adrenaline 1 in 10,000.
Is it in date?
Yeah, it is.
That's adrenaline at 11:26. Start the third. Thank you. And I'll just use a tech flush to flush that. And another one, so it's 20 ml. Start the fourth. Thank you. Let's try. Start the fifth. Sorry, the crew should be here in a minute, so I can give you some relief. End of the fifth. So just checking again. There's still no pulse, so can you continue compressions, please? Where are you in?
Start my fourth.
Just setting up some fluids. Turn that on.
Start the fifth.
Thank you. It still looks like a normal sinus rhythm. no pulse. Can you continue compression, Steve? Now give a second lot of adrenaline. So turn off the flippers. Make sure that flushes through. So the second adrenaline at 11 to at 12 o'clock. Whereabouts are you, Okay. So you've just got to think about what might cause this man's arrest. Talk to family.
Yeah.
But they're downstairs, they're quite upset at the minute. So
Yeah, probably best not.
But I'll think about reversible causes, hypovolemia, if there's no signs of bleeding or anything. If there are, we're treating that with fluid anyway. Hypothermia, we could do some OBS. Hyperkalemia, glycemia sort of thing.
And the fifth, please.
Thank you. Right, so it looks like a normal sinus rhythm again. I can feel a pulse. So can you just check a radial, please? So that's Roscoe at 11:31.
Can't actually feel radio.
Can't feel a radial?
No.
Right, okay. Then we'll continue with, to keep fluids running.
Yeah.
Just to have a reassessment of from our ABC perspective.
The bone injection gun, or the BIG, is the world's first spring-loaded automatic I.O. device. It is designed to allow vascular access when a patient's vein cannot be found in a timely manner, often during an emergency. Invented by an orthopedic surgeon in the late 80s, the BIG is compact, disposable, has a shelf life of 5 years, requires no maintenance, and is used in more than 45 countries worldwide. The BIG is leading the market in automatic intraosseous devices around the world. The BIG is designed for use in all clinical settings, including hospitals, ambulances, rescue teams, and the battlefield. It fits in every pocket and is ready for use anytime, any place, and anywhere. There are two versions of the device, a blue adult unit with a 15-gauge needle and a red pediatric unit with an 18-gauge needle. Regardless of the needle's gauge, both devices have the same basic components: a red safety latch, a shaft that houses the spring, piston, and needle, a red or blue barrel with directional arrow for correct deployment, and safety wings to ensure proper handling. The pediatric BIG is intended for use in the proximal tibia on term newborns to children 12 years of age and features an adjustable barrel to determine penetration depth according to the patient's age. Depths range from 0.5 centimeters to 1.5 centimeters. The adult BIG is intended for use on patients aged 12 years and up. It's preset to an insertion depth of 2.5 centimeters or 1 inch and can be used in both the proximal tibia and the proximal humerus. The BIG does not require any assembly or any outside power source. Simply peel the packaging in the designated location and hold the BIG with your non-dominant hand by its blue or red barrel. The safety latch should never be removed before the BIG is positioned firmly on the designated anatomical site. Make sure that throughout the procedure, the BIG will be held by its red or blue barrel only. Again, the BIG is FDA approved for use in two major sites, the proximal tibia and the proximal humerus. The proximal humerus site can be used for adult patients only. Use the red pediatric big on term newborns to children 12 years of age. Use the blue adult big on patients 12 years of age and older. In both adults and pediatrics, the outset point is the tibial tuberosity. To locate the tibial tuberosity, palpate down from the patella, or kneecap, toward the foot until you feel a rounded protrusion. This rounded protrusion is called the tibial tuberosity. For adult placement, begin at the tibial tuberosity and go approximately 2 centimeters medially or toward the inner part of the leg to find the flat portion of bone. This is called the tibial plateau. From the tibial plateau, go up approximately 1 centimeter or 1/2 inch proximally toward the patella. Our goal is to deploy the needle through the thinnest portion of the cortex and in the area that contains the highest vascular content. For pediatric placement, find the same outset point, which is the tibial tuberosity. From the tibial tuberosity, go 1 to 2 centimeters toward the inner part of the leg to find the flat portion of bone called the tibial plateau. From the tibial plateau, go distally or down toward the foot, approximately 1 centimeter or 1/2 inch. Now, using the red barrel, adjust the big's penetration depth according to the patient's age. The age and length are both marked on the device. The markers are 0 to 3 years, 0.5 to 1 centimeter. 3 to 6 years, 1 to 1.5 centimeters. 6 to 12 years, 1.5 centimeters. Once placement and depth are determined for either device, use your non-dominant hand to hold the red or blue barrel firmly at the penetration site. Hold the big at a 90-degree angle using the aseptic technique throughout. Lay the palm of your hand on the leg while holding the big in place. This will add stability to the technique. While holding the barrel firmly, pull out the red safety latch with your dominant hand by squeezing the 2 sides together. Do not discard the red safety latch because we will use it again later. While continuing to hold the barrel firmly against the site, place 2 fingers of your dominant hand under the wing portion and the palm of that hand on top to stabilize when triggering. Use consistent and gentle downward pressure to trigger the big. Note that no extra force is required. Pull out the trocar by pulling upward and twisting. Only the cannula remains in the bone. Always discard sharps, such as the needleless cannula, into the sharps container. Use the red safety latch to provide additional stability. Push the red safety latch around the cannula and tape it down. Bone marrow can now be aspirated into a syringe for laboratory sampling. However, do note that a lack of bone marrow does not mean the IO is improperly placed. Connect a stopcock or an extension set to the cannula. Flush 20 to 30 cc's of saline before injecting fluids or drugs. In conscious patients, consider administering a local anesthetic prior to administering fluids. Fluids and drugs can now be administered as required. As always, follow your service's protocols. To remove the cannula from the bone, use the square notch in the red safety latch by placing it around the cannula hub. Pinch the combination between your fingers and pull straight up. Some twisting may be required. The bone injection gun family of products include reloadable training devices, manual reloading tools, automatic reloading tools, and the first of its kind adult intraosseous training leg complete with replaceable skins and simulated bone cartridges. To learn more about these products, contact us at www.ps-med.com.
We're going to walk through how to do a rapid sequence intubation. The first thing you want to do once you have your patient is to make sure that they have 2 functioning IVs. That's what you're going to use to push the medications as well as any IV fluids you may need for support. Oxygen, right? You want to have that patient on oxygen. You want to have, obviously, the oxygen source for this intubation. And you want to have your patient on a monitor. In terms of monitoring, they need to be on a cardiac monitor. Whether you use your defibrillator pads or not is up to you, and pulse oximetry. You want to make sure that they're oxygenating their blood, and you're going to be using that to make decisions while you're intubating your patient. I like to make sure that I have my team ready. I'll typically be at the head of the bed with my RT, and I'll have my nurse with my medications at the IV site. They both assist me with intubation as well as monitoring the patient's vital signs. The next step that's really important is to give that patient a period of pre-oxygenation if you have time. And it doesn't really take more than 5 to 8 minutes. What I mean by pre-oxygenation is giving them that chance to really fill up their lungs and get their oxygen level as high as possible, so it can give you that buffer if you run into some trouble while they're paralyzed and sedated during your intubation. If they're awake and conscious, I'll have them on a high-flow nasal cannula as well as a non-rebreather mask, and I'll tell the patient, I'll say, please, I want you to take 8 to 10 deep, slow breaths, vital capacity breaths, really big in and out. If they're not conscious and they can't follow instructions, having them on the high flow nasal cannula and the non-rebreather is still important, and they'll be oxygenating themselves as they breathe. So while your patient is pre-oxygenating, it's a great time to do your equipment check. I like to have all of my equipment laid out in front of me on the right-hand side with my RT, and you want to go through each piece of equipment to A, make sure it's there, and B, make sure that it's working properly. The first piece of equipment is going to be suction, right? This is a Yankauer tube. You want to make sure that it's working, that it's connected to a suction canister, and that it's somewhere you can find it without needing to look. Oftentimes you'll run into vomitus or oral secretions or blood while you're looking at the vocal cords, and you want to be able to suction that out immediately. I'll take this and tuck it right here underneath the mattress or the pillow at the head of the bed. That way, if I'm looking at the vocal cords, I can blindly just go and grab it. The next piece of equipment is going to be your laryngoscope. The laryngoscope is what you're going to be using to visualize the vocal cords. This one has a Mach 4 curved blade, which is my preferred blade. There are straight Miller blades that we'll sometimes use for peds, or if it's a preference of yours, you can use a Miller blade. I'll have a backup smaller Mach 3 that I'll use for smaller adults or children. You want to make sure that the light is actually working, right? That your batteries haven't died while it's been sitting in the drawer. So make sure that light source is solid and turns on every time you engage that blade. Your next piece of equipment is going to be your endotracheal tube, your ET tube. This is a 6.5, but typically I'll have at least a 7.0 and a 7.5 for my standard size adult. Sometimes bump it up to an 8.0 or 8.5 for a really large male, or it can go down to about a 6.5 for a smaller individual. But those are my standard go-tos, 7.0, 7.5 on the tray. They'll be close by if you need to switch it out. In terms of your endotracheal tube, you'll also need a rigid stylet, right? So this is a rigid stylet. It has an obturator on the end, a rubber obturator. And what you're going to do is use the stylet into the ET tube to give it some form so that you can manipulate it into the airway. And when you're going to be changing the form of that stylet, I like to have it like a hockey stick, right? So it's really straight, 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 straight. And right before the balloon at the end, you do a 35 degree angle anterior. That's going to help this tube go into the airway, which lies a little anterior. If it's too straight, you have a risk of it going into the esophagus. And if it's too angled, you're just going to get hung up on the vocal cords. You do not want it to go beyond the eyelet of the ET tube, right? So the tip of your stylet should not be protruding outside. That's going to cause damage to the airway. I tuck it in right before the eyelet starts on the ET tube. So now it's all prepped up and styleted. The next step is to make sure that your balloon is actually functioning, right? So I'll take a 10 cc syringe, and I'll fill the ET tube balloon and make sure there's no air leaks. You can feel it. It's nice and tense. No air is escaping. At that point, you deflate it again so that you can pass it through the vocal cords easily. I'll set that to the side. My RT will know where it is, so it'll be ready. I want to make sure that I have a bag valve mask, right? It's the bag that you'll be attaching to the end of the ET tube to actually inflate the patient's lungs. and a mask, right? A mask is a good thing to have because if you run into trouble with the intubation and you need to oxygenate the patient in between attempts, well, you're going to bag valve mask them. And we show you how to do that in a previous video. I also like to have some other rescue devices, right? The first one I'm going to have is going to be a bougie. This one's twisted up for storage, but I'll teach you how to use this if you're having a hard time seeing vocal cords or getting the ET tube in. The other backups I'll have will be an oral airway for my bag valve mask or even an LMA, and we'll teach you how to use all of these in separate videos. You'll need an end-tidal CO2 device. This is a small plastic device that will change colors to confirm that you're in the airway. When there's CO2 exhaled from the lungs, it goes from yellow to purple. Alternatively, if you have an end-tidal CO2 monitor, you can connect that to the end of your endotracheal tube, but it just helps you confirm that you're actually in the airway and not in the esophagus. I'll make sure that I have a set of McGill forceps. These are really handy to have if you have something blocking the airway. They're ringed at the ends, so they're blunt, and they're shaped just like the airway. So when you're in there looking at the vocal cords, if there's something obscuring it, a foreign body, you can go in there, grab it, pull it out. It's also useful to help lift up the tongue sometimes if you're getting caught up on that. And then finally, I'll just make sure that A, my RT is ready, that my monitors are on, that my nurse is ready with my medications, and we'll proceed from there. The next step is to make sure you have your patient properly positioned. So I'd be at the head of the bed with my RT at the right, all my equipment at the right, my nurse at the IV line. We can all look at the monitor and monitor that patient. And then I'll have that patient's head right about the height of the lower end of my sternum. I don't want to be bending way over to see the vocal cords. It gets awkward and it makes it difficult. So bringing them up to the lower end of my sternum is just about right. You also want to make sure that you have that patient in the sniffing position that we discussed in a previous video. The sniffing position is a little bit of flexion at the head and elevation at the occiput. So you're really straightening out the angle of that airway, trying to make it as straight as possible for your look and for your intubation. In order to do that for your patient, you're going to, again, just flex their head as long as there's no C-spine precautions, just a little bit of flexion, and I'll often add a small pillow or a towel roll at the occiput to give that elevation. It really brings up the jaw and decreases that angle. Once they're positioned and everyone's ready, I'll have my nurse or my pharmacist push my medications, the sedative followed by the paralytic, and then you wait. You wait to make sure that your patient is sedated and paralyzed, realizing that this can take anywhere from 30 seconds to sometimes 1 to 2 minutes, so be patient. You want to make sure they're sedated because they won't be responsive, and the great way to figure out if they're paralyzed is looking for that laxity in their jaw. When you're moving their jaw, and there's a lot of laxity, you feel that musculature kind of chill out, then you know you have good paralysis. And you're ready to move on to the next step, which is actually looking at the vocal cords. It's at this point that I'll remove the oxygen mask. I'll leave the nasal cannula just for some apneic oxygenation. You want to grab your laryngoscope, and when you hold it, I hold it in my non-dominant hand, my left hand, with the butt of the blade at my hypothenar eminence, 4 fingers grasping here, and my thumb on the handle for control. And when you're going to be using this, you're going to be doing a lifting motion, not a twisting motion, not a flexing at the wrist. It's really going to be an in and lift. I'll go to the patient's mouth. I'll oftentimes use my finger to pull that cheek so I can really get good visualization of the tongue. I'll place this blade into the right side of the mouth, sweeping the tongue towards the left as I bring that blade midline. And this part is where it's really critical. You don't want to be using the teeth as a fulcrum, right? You're not going to be flexing here. That's how you break people's teeth. It's really a in and a lift up. And I almost visualize it as I'm trying to bring that patient's chin to touch the sky. So I'm really lifting up here. A good 90-degree angle at the elbow and being close to the patient is going to help you make that move. And while you're doing that, you're looking, right? You're going to be looking for the epiglottis. Once you see the epiglottis, you want to tuck that blade forward into the vallecula, which will pop the epiglottis out. And then you can see the vocal cords staring at you, 2 white vocal cords. If you're having difficulty actually seeing the vocal cords, you can do external laryngeal manipulation where you're pushing down on the thyroid to bring the vocal cords into view. Once you found them, you can have your assistant hold it there. Alternatively, you can actually move their hand and they'll hold it where you need to be so you can see those vocal cords. You keep your eye on it. You'll ask your RT for assistance, hands you the ET tube, and you want to watch that ET tube go through those vocal cords. And once you're in there, you want to go 3 to 4 centimeters beyond the vocal cords. Remove your blade. Hold that ET tube against the teeth with your hand while you remove the rigid stylet. And at this point, your RT is going to inflate the balloon, or you're going to inflate the balloon. We'll put on our end-tidal CO2 detector once that balloon's up. And you now want to confirm that that ET tube is in the airway. Give a couple breaths. You're watching for color change on the end-tidal CO2, again from yellow to purple. And then have someone, either you or your RT or the nurse, listen to the bilateral lungs in the axilla and the epigastrum to confirm that they're hearing breath sounds over the lungs and not over the stomach. So once you've confirmed that the tube is in the airway, you can now focus on making sure it's positioned correctly. You want to get a post-intubation X-ray. You'll secure that tube, whether you use tape or a commercial product that actually secures the tube into the mouth around the neck. And you want to have your RT connect them to the ventilator, and your nurse and your pharmacist work on the post-intubation medications, sedation and pain control, so you do not have an awake patient with a tube in their throat that has the risk of actually pulling it out. And those are the steps for your rapid sequence intubation. The next step is really going to be making sure you have the tube in the right place with an X-ray, securing the tube with tape or a commercial device, making sure that your patient has post-intubation sedation and pain control, and vent managing. But really, the RSI, these are the steps that you need to do, and you'll be successful.
Hi, I'm Russ Hall. I'm the EMS coordinator for the Holden Fire Department. I'm just going to go through the difference between BLS level ambulance and the department's ALS level ambulances. As you can see over here, BLS ambulance is basically equipped with basic first aid equipment, bandages, oxygen supplies, ice packs, fluid to irrigate wounds, backboarding equipment, and different splints. To set up a BLS ambulance, you see the equipment that we need to take into somebody's house is basically what we call a first-in bag, which has your basic first aid equipment, an oxygen bag, which has a portable tank in it, and a semi-automatic or automatic external defibrillator, which EMTs can operate in case somebody goes into a cardiac arrest. That's pretty much the only equipment, if you're running a BLS ambulance, you're going to transfer between trucks. Would be those 3 bags. The rest of the stuff is standard in Massachusetts ambulances statewide. For the ALS equipment, as you see here, we have a lot more than just a couple bags of equipment that we have to move around and stock the ambulance with. It's all required by Mass DPH. In our ambulances, we carry a Medtronic LifePak 12, which is a monitor which allows us to do 12 lead EKGs in the field. We can manually defibrillate somebody. We can put an external pacemaker on somebody if they need, if their heart is failing and we have to get their heart rate up. We have the ability to do automatic blood pressures with this and keep track of their vital signs. This is quite a sophisticated piece of equipment. Our ALS first-in bag is much more in-depth than a BLS bag. Contains a kit to put an airway in somebody if they need by intubation, which is putting a tube down somebody's throat to breathe for them. We have IV supplies in there. We have supplies for diabetics. We have drugs, as well as your routine first aid stuff. We also carry a drug box, which is full of all the required drugs by the state of Massachusetts to treat all the different illnesses. We have backup drugs which we must carry. We have a CPAP equipment, which is also used for airway people with congestive heart failure. We can do that. It's a positive pressure airway, keep their airway open. So all this equipment is all part of the ALS package. Then we have to stock the ambulance with a certain amount of ALS equipment, which is really not transferable from truck to truck. It kind of has to stay in the vehicle. And that includes spare IV catheters, spare syringes, spare fluids. And we have to carry a certain amount of IV fluid, administration sets for the IV fluid, extension sets for the IVs, and we also have to carry different airway supplies. We have to have spare endotracheal tubes, we have to have spare meds, we have to have spare supplemental airways in case we have somebody that's very difficult to intubate and we still have to get an airway in them. We have to carry those on the ambulance. And then we also have another cabinet full of spare ALS supplies. This is all our spare monitor and cardiac supplies, spare electrodes, defibrillator pads. We have to carry spare batteries for the monitor in case we have a malfunction. We have to carry a spare cable. For every cable that's on that cardiac monitor, we have to carry it with us in case there's a malfunction when we're taking care of a patient. So the ALS portion of the ambulance is very in-depth. It's not really something that you can carry in a couple bags.
Right.
It's a lot of equipment, but it's necessary equipment.
Yeah.
So when we get to a call, we have the ability to do what we're trained to do, and our hands aren't tied to just do basic first aid.
Right.
That's pretty much it.
And what's the value of having the new third ambulance be equipped for ALS?
Well, there's many reasons why you'd want to equip every ambulance the same way, because it's continuity throughout the whole department. We operate under a paramedic basic staffing waiver, which means that we can run an ambulance out of here with one paramedic in it and one EMT rather than two paramedics.
Okay.
That would enable us, when both of our primary ambulances are out, if we have another call, if we get a paramedic that comes back into the station, that ambulance can also go out as a paramedic unit. It's also nice to have spare equipment. Right now, where we started the service up a year ago, we pretty much have the equipment in the two primary trucks. We don't have spare stuff, so if one of our monitors malfunctions, we're out of service with one ALS truck for the time for it to get repaired. You know, it's nice to have spare equipment, basically, for a service, especially a service that does the amount of calls that we do.